Very good. Thank you all for coming. We want to welcome everyone to the North Peninsula Democratic Club's membership meeting and our panel discussion, Making Sense of Healthcare Reform. We're lucky to be joined by a number of experts on the issue, and they'll provide some perspective on this issue of healthcare reform that we've been hearing so much about in the media of late. I think there's a sense that there will be some healthcare reform legislation passed. The question is, what will that look like, and will it actually make an impact? I wanted to just make a quick note. A number of our members, as you can see by our small crowd, a number of our members were not able to be here. There are a variety of events happening and scheduling conflicts, so we've taken the liberty of videotaping tonight's panel, and we'll be putting that up on the web so our members and other Democratic activists in the county can have the benefit of this panel discussion. So our panel has consented to letting this be videotaped, so thank you very much for that. So let me go ahead and introduce our panel. On the end, Brian Perkins is a legislative aide to Congresswoman Jackie Spear and is the lead on following healthcare legislation for the Congresswoman's office. I've had the pleasure to work alongside Brian when Jackie was in the State Senate and Assembly. Brian is the Dean of Peninsula Legislative Aides, having worked for Assemblymember Ted Lempert in the early 90s, and more recently is a county legislative aide to Supervisor Adrian Tissier. Brian has a master's degree, among other degrees, in business administration from Stanford University. So thank you very much for taking the time, Brian. Ellen Schaefer is a founder and co-director of the Center for Policy Analysis, an independent organization dedicated to protecting human health and expanding access to healthcare, water, and other vital human services. Ellen writes and lectures extensively on access to healthcare, women's health, and globalization. She served as a senior health policy advisor to U.S. Senator Paul Wellstone from 1992 to 1995, guiding staff work on national healthcare reform and managed care patient rights. Ellen also co-authored the chapter on politics in the latest edition of Our Bodies, Ourselves. She has a master's in public health from UC Berkeley and a PhD from the School of Hygiene and Public Health at Johns Hopkins University. Thank you very much, Ellen, for taking the time to be here. Srija Srinivasan, I want to make sure I get that right, is a special assistant to the county manager on the Health System Redesign Initiative. Srija serves as lead staff for the initiative involving the health system, the health plan of San Mateo, and all of the major healthcare delivery organizations serving our county. This two-year initiative aims to design and implement a new sustainable and creative approach to healthcare delivery that incorporates key recommendations of the Health Management Associates Phase 2 final report and the recommendations of the Blue Ribbon Task Force on adult healthcare coverage expansion. She also oversees the Children's Health Initiative, which provides universal health insurance for children in San Mateo County. Srija has more than a decade of experience in health policy and community health issues, including several senior roles in the public, nonprofit, and philanthropic sectors. She received her BA and MBA degrees from Stanford University. So let's go ahead and thank you very much for being here. Brian, let's go ahead and start with you, if we may. Give us an overview, if you can, of the legislation that we've been hearing about in the media that's moving through Congress right now, and maybe a bit of political analysis on what that final bill might look like and the likelihood that we're going to see meaningful reform this fall.
Wow, just a small job. Well, first of all, let's start with what's going on. We're having, the way I usually say is we're having 2 or 3 discussions all at once, and that's part of the reason why there's a lot of confusion. We're having a discussion about extending health care to people who presently don't have health insurance at all. There's, depending upon your estimates, the president likes to say more than 30 million, some people say 47 million, whatever, choose the number that you want. There's a separate discussion going on about Medicare, and that's sort of, it's there and yet it's not. It sort of comes into focus and not, and we'll have a discussion, I'm sure, about that tonight. And going over all of this discussion is a discussion about the cost and quality of healthcare in America today, neither of which is particularly good from the standpoint of those that know a lot about healthcare in developed countries around the world. We have a lot of problems with cost. We all know that. What we're coming to grips with is some of our problems with quality.
There were 2 committees of jurisdiction on the Senate side. Senator Kennedy's, the late Senator Kennedy's Health Committee, Health, Education, Labor, and Pensions, which did pass a bill. And now we're in the Finance Committee. which is chaired by Max Baucus, who is infamous to many of us for having put together a draft bill trying to compromise with the Republicans and put together a draft that doesn't include what we call the public option. So maybe I'll just talk about that for a minute. People have heard about this controversy, I imagine. Not so much. Okay. Well, let me talk about what that would do. And the fact is that the Finance Committee is supposed to vote tomorrow on whether or not this public option will be included. So you mentioned single payer, and I'll tell you how single payer is related to the public option. Have people worked on single payer, or you're a little bit familiar with it? Not a couple of people. We passed that a few times in California. The idea of single payer, in contrast a little bit to the system that we are talking about and that Brian described, is that it's a system pretty much like Medicare, which some of us I think are familiar with. And the idea, and what is different about it is that it's not private for-profit insurance, and you don't have to sign up for it, and pre-existing conditions are not an issue. Basically, we all pay for Medicare as we go along through our working lives, as we pay for it out of taxes, and once you become 65, and in some cases you have certain medical conditions, you are covered. There are rules, there's still co-pays and deductibles for various things, but coverage is not a question, and the administration of Medicare is much more efficient than the administration in these private for-profit plans, partly because it's not for-profit, and also they don't spend a lot of time figuring out if you belong there or not, or what benefits you have. It's just pretty straightforward. So the administration in Medicare is about 3%, and in these other plans can be as high as 30%. Now, given that what President Obama has said on many occasions is, gee, if we were starting from scratch, seems like a pretty good idea, and it is popular. We have had state legislation in California that's passed through the legislature a couple times, has been vetoed by the governor. But the fact is, as Brian was saying, part of the problem here is that we're spending $2.5 trillion a year, and we're not covering everybody. That's a lot of money, and to many of us who are who are trying to use the system, the idea is that you want to control those costs. On the other side of the ledger, however, are all the people who are getting that $2.5 trillion, and that includes the insurance industry and the drug companies, as well as a lot of providers and hospitals. So there's a conflict in terms of how we're going to control costs and who's going to do that. So while there's agreement that having a completely government-run system would be the most effective way to put the brakes on the costs, because you've got the 300-pound gorilla in there negotiating with the drug companies, there's political resistance to that idea. So the compromise is having the kind of health exchange that was described, and you can go there as sort of what state employees do. You pick a plan out of this regulated group of insurance plans, but one of them is what we call a public plan, and it would be administered by the federal government, probably. I mean, there's arguments about exactly how it would be devised, but the sponsor would be a government sponsor, therefore the administrative rates would be low. And the hope is, A, that something like this would be offered, and secondly, that it would be configured in a way that it really would work for people and save money.
Well, thank you for having me. Thank you all for your interest in this. And I'll just say at the outset, I'm a public servant, so I don't have a point of view per se on something that's active legislation, but as a public servant paid by your tax resources, this issue of health reform is really important to local communities, and basically the county, as a safety net and as the protector of public health for all 700,000 residents, has a real interest in some meaningful federal health reform. Our vision is for a healthier next generation. We do things like inspect restaurants and make sure that we have safety and stop the spread of H1N1 and those kinds of things. But because we don't have a healthcare system in our country, local governments and nonprofit organizations, whether it's hospitals or clinics or physicians, end up taking care of the many people who don't have health insurance.